Welcome, everyone. We're thrilled that you're joining us this evening on a hockey night in Canada for our Johnson & Johnson sponsored ORNAO webinar series. This evening, we are absolutely delighted to share surgical stewardship of the prevention of surgical site infections. We have three speakers this evening. We will start with Angela Texan. Angela is affectionately known as Mama QI by her colleagues and peers, and is the Director of Clinical Quality and Specialty Safety at Fraser Health. With over 18 years of experience in quality improvement, Angela brings a strong background in both data and surgical nursing to her leadership of surgical safety and physician partnership initiatives. We will then follow with a collaborative approach. We have Peter Graves, and Peter is a well-known independent perioperative nurse consultant with a deep passion for surgical infection prevention and evidence-based practice education and research with more than 35 years of experience. You may recall Peter from previous webinars and most recently at the Halifax National Conference for ARNAC a number of years ago. Maureen Spencer is collaborating with Peter on this discussion tonight and has been board certified in infection control for over 40 years and is an independent infection preventionist consultant. She serves as a consultant for Health Consulting, University of Massachusetts Medical School, and was recently a manager infection control unit at New England Baptist Hospital. We welcome everybody this evening and all of our attendees. I see the numbers up to around 80 tonight. I think they may go a little bit higher. In the interest of a jam-packed agenda, we're going to hand it over to Angela to launch things off. Just a reminder, any questions in the Q&A or chat. Angela will be gone before the end of the session, but she will leave her contact information for any follow-up. Without further ado, I'd like to welcome you all and thank J&J. I'm going to hand it over to Angela now. Thank you.
Good afternoon, everyone, and thank you for the introduction. Thank you to Johnson & Johnson for the opportunity to share our experience today. I also want to acknowledge our amazing NESQIP team at Fraser Health. They helped pull the slides together and have truly been the driving force behind this initiative. Fraser Health is a large and complex system. We have 11 surgical sites participating in the ACS NESQIP program, from small rural hospitals to large teaching centers. We've been in the program since 2006, but until recently, each site worked fairly independently on their own improvement efforts. So that changed 4 years ago when we regionalized the NESQIP support. That meant centralizing data support, aligning leadership roles, and creating dedicated capacity for collaborative quality improvement activities. So the shift to regional support allowed us to move from isolated efforts to system-wide collaboration. So our regional team is focused on building capacity and rebuilding the trust in the data in 2020, then moved to shared initiatives. So we did delirium in 2021, and then by 2022, we turned our attention to surgical site infection. So our priorities were guided by what the NESQIP data was telling us. So aside from individual site reports, we look at the entire Fraser Health collaborative for benchmarking. And we also compared our region against BC and Canada. So you'll see that SSI, we've got about 8 sites that needs improvement. They are in the red, and we only had one better than NESQIP. And we also are worse compared to BC and Canada. So the data was clear. We need to work on our surgical site infection. And SSI carry a significant burden. They extend hospital stay for an average of 7 days. They cost around $50,000 to $92,000 per infection, and they directly impact patient recovery, experience, and system flow. So when we saw the persistent red flag in our NESQIP reports, we knew that we needed a coordinated regional response one that was data-driven, collaborative, and scalable. So we had been working on SSI prevention for 15 years. All sites addressed SSI and implemented all these bundles. We did environmental scan, and we found out about the many changes made over the years. From pre-op, intra-op, post-op, we embedded them in order sets. And we found out that we've done almost everything right. But what we learned is that good practices alone aren't enough. So too many changes made it hard to see what worked. Change fatigue is real. We need buy-in from surgeons and staff. We need to align tools across the region, and we need a way to adapt the change to fit each site's culture. So our data drill down in 2022 gave us more insights. We saw, like you will see, that we saw common cause variations in our data. And during COVID, it made the variations wider. So many of our surgical site infection occurred after discharge, around post-op day 11, and often later on picked up in ER visits. This is our driver diagram when we established our collaborative in 2022. This was co-developed with our surgeons and anesthesia champions, our nurses, leaders, and patient partners. Now, before you picture a massive overhaul, this wasn't that. We asked ourselves a simple question: what small, high-impact changes can we make that are easy to spread, and stick? And from all the data review, process mapping, and clinician engagement, and with a small regional team, 2 strategies emerged. So we landed on 2 core strategies: the antimicrobial sutures, that's in partnership with Johnson & Johnson, and patient education in partnership with the American College of Surgeons. There's actually a patient education toolkit that is available for NSQIP participants. So we ran into PDSA cycles for the suture, not just to automatically switch the product, but to understand how each site could make the transition. Some sites needed side-by-side comparison, others needed myth busting. We embedded support in procurement workflows. We hosted info sessions in the OR, leaned on to site champions who were passionate about the evidence. Now, for the patient education, it was really cool to have that the website, the toolkit that is co-developed with the American College of Surgeons. This toolkit was reviewed with surgeons, patient partners, and customized it for site-specific content. So some sites integrated it into their pre-op consults, others embedded it into their discharge handouts. Some use it at their clinics, and I think that's the beauty of the collaborative. There is flexible in execution with shared goals and different paths. So now for the result. So between 2022 and 2024, our SSI rates trended downward across the region from 8 high outliers, this part here in 2022, went down to about 3 in 2023, now 1 in 2024, and we even have one like extremely doing better than NSQIP. And this is our Schuhart chart for superficial SSI. It trended down a bit. We're still waiting for the 2024 data. I think it's going to come out in July. So we also measured sepsis and readmission as our balancing measure. We made sure that we weren't shifting harm. Sepsis dropped down below the NSQIP average. I cannot confidently say that the decrease in sepsis in 2022 is attributed to the SSI initiative, but hey, it went down below NSQIP average, so that's a win for us. And readmission remained stable. And so what did we learn? Start small, but start. Use your data. I'm just sharing here some examples of the dashboard on the capability of the NESCOP data and how it can support us in driving improvement activities. Celebrate your champions, surgeons, nurses, educators, leaders, and above all, don't let perfection stop you from making progress. So we didn't fix everything overnight, but by focusing on simple, scalable, system-level change, we're building momentum that is real. So the work is still ongoing, and these are just a dashboard, and we're just showing transparency and feedback that they're key to improvement. This is my team who helped me develop these slides. And thank you. On to you, Peter.
Thank you, Angela. I'm going to share my screen. I hope everybody can see that. Great job, Angela. Really good data, and I'm proud of what you guys were able to accomplish. So good evening, everyone. My name is Peter Graves. I'm from the Dallas, Texas area, and it's a little warm down here, about 34 degrees Celsius, and I'm happy to export some of this warmth up your direction. But tonight we're going to talk a little bit about utilizing an evidence-based approach. We call it the 7S bundled approach to reduce the risk for surgical site infection. Much like what Angela talked about is what we're going to be focused on. You already know who we are. So over the next few minutes, we're going to talk about the 7S bundle and how it establishes a fundamental framework for surgical site infection prevention. We're going to talk about the implications for clinical practice and patient outcomes. We're going to describe some of the US and other global impacts that surgical site infections have had, and that includes all of you in Canada as well. So as Angela really nicely described the costs associated with infections, surgical site infections account for about a little over a third of all healthcare associated infections in Canada. And as Angela did a nice job describing, it leads to increased hospitals' costs significantly. And SSIs are not just a Canadian problem or a US problem, it's a global problem. And I think that's one of the things that we have to recognize, the fact that when we look at some of these SSIs, it's not a unique problem just to your facility. It's across the entire continent. So when we look at SSI guidelines, some of the ones that she talked about was the American College of Surgeons, but there's also the World Health Organization. She mentioned the American College of Surgeons, Surgical Infection Society, Society for Healthcare Epidemiology, Wisconsin, the state of Wisconsin here in the United States, the Centers for Disease Control, and then NICE, which is the European standards. But when I put all of these together and I look at the top 8 elements that are typically associated with SSI prevention initiatives, so let's start I'm not going to go through all of these, but just on a couple of things. Normothermia, for example. It's pretty standard across every single guideline that you need to keep the patient warm. I don't think it's really a big surprise there, but one of the challenges you have is when we go down to the next one is wound irrigation. There is no global consensus on wound irrigation. When you look at WHO, the World Health Organization, it doesn't correlate with the American College of Surgeons. And so I think this is one of the big challenges we have, is which guideline are we going to use in order to be able to achieve or chase 0 infections within your hospital. When we take a look at things like blood sugar, maintaining the blood sugar at 120 milligrams or less, or in some guidelines, 200 milligrams or less, again, all of them are pretty consistent and we can keep going down. But one thing that Maureen and I found on a study that was published in Surgical Infections, we assessed the hospital's implementation of all the guidelines, well, actually 7 key guideline elements. And what we found was that hospitals implemented the simpler elements, not the more difficult elements. And that we have to be able to implement all the elements in our facility to be able to achieve the best results. And I think that's one of the big takeaways I would hope that you take back to your facilities tomorrow, is that we need to be able to implement all the elements of these guidelines. Now, when we talk about the 7S bundle, there's 7 key elements, or 7 S's. The first one is your operating room safe? Are we screening our patients? Are the patients coming to surgery clean? Are they performing showers? Are we doing skin prep properly? Are we using the right antimicrobial sutures, as Angela talked about? Are you using the right solution? Or what about surgical irrigation and then skin closure? So is your operating room safe? And I think one of the biggest challenges that we see as we go about and do surveys on hospitals and we do educational programs is that there's a lot of times that there's a lot of people in our rooms and the door is constantly opening and closing. Or we may not be using skin prep correctly, or we may be clipping hair in the OR, or we have a lot of equipment blocking air return vents in the operating room. There's a lot of different things that we may be doing or not doing that may make your facility less safe than others. So when we take a look at like the ORNAC standards or the AORN standards, because they really do match up nicely, one of the things I would always say is that make sure that our operating rooms are as safe as possible. This is one really important element. When I take a look at evidence-based guidelines, now, as I mentioned earlier, the ORNAC guidelines, they don't match up exactly word for word with AORN, but the elements are almost all the same. But there's 3 key buckets in and around infection prevention in the operating room. Aseptic practices, which makes up these 5 elements, patient and worker safety, sharp safety, transmissible infections, and environmental care, making sure our environment's clean, and then sterilization and disinfection, which are typically 5 key elements as well. But if we're doing all of these and have them all implemented, it really does assist us, gives us a really good roadmap for training, education, not just of the OR staff, but also the surgeons, anesthesia, the residents, and even medical students, so that we have kind of a common hymnal in which we're singing from. Because I think we all sound really good when we sing on the same page in church. Now, something that's interesting that I talk about quite a bit is how often are you changing your gloves? It was something interesting that AON came out with last year, and it was an evidence-based review of how often do they recommend changing gloves. So on open abdominal surgery, on oral maxillofacial surgery, and arthroplasty, total joints, they recommended changing your gloves every 60 minutes. Now, I'm not going to read this whole list, but one of the challenges that you have is oftentimes that we should all be double gloving. So, but if we have a microperforation on our outer glove, we may not detect it unless we have a colored underglove. So one thing I would encourage everyone, regardless of where your practice setting is to double glove in all procedures with a colored underglove and have a standardized time in which you should be changing your gloves. This is really important because what's inside will escape out into the wound should you perforate both gloves or a single glove if you're just wearing one. Air quality is a huge issue within operating rooms. And if you take a look at the key recommendations, you talk about we need to make sure that we keep those doors closed so that we have the environmental contamination within our rooms minimized. Because when I open that door, the air pressure changes, particularly when we're using laminar flows. We need to have an air quality management program. So if we don't have one in your facility, you need to maybe think about that in the future. We need to, part of those things that we're looking at from a quality improvement is looking at the equipment within your room, the environment within your room, and any of the personnel actors, that would be surgeons, anesthesia, any of those staff members that are within the room interacting that can interfere with airflow. And then when you do have an SSI that you identify, that you need to be looking at air sampling data if you have it. And if you don't, there are a number of different equipment opportunities to have or to install that you can look at air quality within your operating room, particulate matter, and so on. But it's interesting because most of us in North America are using laminar airflow. And it's interesting, you'll see the picture on the video on the left, you'll see what happens with the smoke that's released into the air, because on the outside of the room, it kind of has a eddy effect. And when I release it right above the operating room table, when a surgical light is illuminated and I have the laminar flow active, between the patient and the light, the air will again act much like an eddy. Now, if I take a look at the picture on the left, I'm sorry, on the right, this is a temperature controlled airflow. What you have is the air coming out of the ceiling. Instead of having the large panels, they have diffusers, and it's 2 degrees Celsius cooler than the room air. And what it does is it pushes all the particulate matter from wherever it's occurring, it pushes it and holds it to the floor, unlike our laminar airflow. What a lot of people don't realize is that laminar airflow was built in designed and implemented in the 1970s. And there's newer systems in Europe that are being used that have higher efficacy for air quality within our operating rooms. We're also seeing, and this goes under the kind of the safety quality aspect, is challenging with hair clipping when we have to clip hair inside the operating room. Ideally, all guidelines recommend it being done outside, and removing any stray hairs should be done prior to the patient entering the operating room. But if they don't, there's a number of different technologies that you can use. One of them is actually a vacuum assist device. And this is an article that was published in the American Journal of Infection Control that Maureen was involved in. And it talks about using a vacuum assist device to collect any of the hair fragments from the patient so that they don't become aerosolized and act as a vector for transmission of infections. I think we all recognize the fact that hair is laden with bacteria. And so it becomes aerosolized. If it ends up in the wound, that could be your nidus for an infection. I think it's also important to recognize the role that cleaning and sterilization of instruments have. So making sure that all of our grooves, our box locks, our lumens are all clean, that we're inspecting the instruments closely. We're using borescopes when possible to make sure that we're not having biofilm buildup inside of lumens. We want to reduce the immediate use steam sterilization, or as for those of us that have gray hair, flash sterilization. And then again, we're seeing more and more bundles, including the use of a secondary tray for wound closure, first adopted into the colorectal space, but now being used in a number of different specialties to reduce that risk of contamination. And if you're going to use a separate closing tray, you need to change your gloves as well. We need to make sure the environment is clean. That means in cleaning the entire room and making sure that there's no missed spots. And again, we're making sure we're using things like microfiber, that we're using facility-approved disinfectants, for example. When we talk about screening the patient, this is a really important preoperative phase of the patient care, because we know that Staph aureus, whether it's Staph methicillin resistant or methicillin susceptible Staph aureus, is a significant risk factor for infections post-op. They say upwards of 70 to 80, almost 90% of staph infections can be linked back to the nose. And there's a 6-fold greater risk of SSIs in carriers of patients with Staph aureus colonization. When you take a look at nasal decolonization, patients positive for nasal MRSA had 20 times greater odds of developing an MRSA infection than those that did not have that colonization. So it really does bode well for us to pay particular attention to the noses of all of our patients. When I'm thinking about decolonization, really it's not just the nose, but it's also the body. So we talked a little bit about nasal decolonization, but again, typically Staph aureus will colonize the anterior nose. About 4% of the population carry MRSA in their nose, and about 15 to 30%. And that, again, that depends on the location of where you are, populations, and so on, can carry methicillin susceptible staph. And so you see a number of different initiatives being used. You have topical antiseptics being used, but again, you have to use what's cleared by Health Canada to be able to use within the nose. Commonly, you see things like mupirocin used. You also have the light treatments. Again, there's a number of different methodologies in which to eradicate this colonized staph within the nose. Body decolonization, we'll talk more about bathing in just a moment. But again, anywhere that is moist, groins, armpits, can also be colonized as well. So this is why we see things like chlorhexidine being recommended for bathing or wipes. And again, if we decolonize these patients, it doesn't just help the patient, it helps the other patients in the area because it prevents the potential cross-contamination from one area to another. As I mentioned earlier, talking about decolonization of the patient, about the importance of showers. So making sure that the patient showers the night before the morning of at a minimum. Now, me personally, I had my hips replaced in the last 18 months, both of them, one at a time. I showered repeatedly with chlorhexidine, 4% in the, twice a day actually, and it reduced my risk for infection. So if you're giving patients bottles of chlorhexidine, give them 2 4-ounce bottles the night before and the morning of, and then have them leave it on the skin for a minimum of 1 minute. This was a study done by Dr. Charles Edmonston and colleagues. Now, I always say the devil's in the details when we're talking about reducing the risk of infections for our patients. So if they're using a 4% aqueous CHG or even a 2% CHG soap, then if you have a text message system within your facility to help send them reminders, for example, it makes a significant difference. But again, have that standardized regime that you can teach and train the patients on the morning of and the night before. And the same thing would hold true if you're using the CHG cloths or not. The next one is skin prep. And I think it's really important also to make sure that we're prepping with this alcohol-based skin prep. Now, what many people don't realize is that when I use an alcohol and secondary agent, whether it's alcohol and CHG or alcohol and iodine, it's the alcohol that does the majority of the work. It's immediate. That the CHG or the iodine product only works at a moderate speed versus a rapid speed for alcohol. So when I have a combination product, for example, alcohol with CHG or alcohol with iodine povacrylics, for example, then it's the alcohol first. And for CHG, it takes about 20 plus seconds for it to start working. The CHG is what gives the persistence, the same thing for the iodine products. So it's important as we look at these different agents that we're using them according to the manufacturer's written instructions. And with that, I'm going to pass the baton to Maureen.
Oh, and thank you, Peter. Let me get this. And this current side. Now that have that. Wait a minute. Jeez. Okay. So I'm going to start now with number 5 through 7, the sutures, solution to pollution is dilution, and skin closure. So sutures are something that's going to be left in the body. So they're really like an implant. And they can have what's called a nidus for attachment of bacteria, anything that we leave in the body, whether it's implants that we think about, or even like sternal wires, or things like sutures, any mesh. These are where bacteria can attach. We call that contamination. And when Peter showed you those air contamination videos, this is what we're finding in the operating rooms, that the dirty zone around the table and the doors opening and closing and the number of people in the room, all of this stuff is coming up through the heat of the whole overhead lights through what's called thermal convection and dumping it down into the incision. And it only takes 100 staphylococcal per gram of tissue for an infection to develop. So they multiply every 20 minutes. And now you've got colonization. And as it goes on, you've got what's called biofilm. And they have a sticky matrix around it so that bacteria are protecting themselves from antibiotics. The good thing is antiseptics can actually, through our biocide, can actually break down that cell wall and kill it. So Dr. Edmonston did the study and published it back in 2006. So these sutures have been around since 2002. I started using them in about, the hospital got them implemented in about 2005 to 2006. But this was one of the studies that we showed our surgeons. He challenged the organisms in his laboratory with Staph aureus, which was MRSA, Staph epidermidis, and E. coli. He did a small amount, 10 to the second, and actually, the 100, and did it 10 to the fifth, 100,000 organisms. And then incubated them overnight, looked at the mean colony forming units, and you can see that the green is the non-coated sutures and the orange is the coated sutures. So you can see that this triclosan, and this is an antiseptic that's used in mouthwash and toothpaste, in deodorants. We use a very small amount of it in our daily over-the-counter. The amount that's on the suture is very, very small, and the body kind of just gets rid of it within about 7 to 10 days, so there's not a lot of exposure to it. The other thing I used to do, which I would recommend if you want to show them what these bacteria look like, because this is when people go, oh, it's like a bug, like an insect, and you see these colonies on the plates, the blood agar plates, which, by the way, they love blood. Blood is like a steak to them. When there's blood in the tissue where you've got bleeding going on, you're just making that wound a sitting duck for these bacteria to grow. So I used to take these blood agar plates. I used to work with the lab, the micro lab, to give me some plates and put them on the anesthesia card, around the room, on computers, any kind of a table I could put it on, and then we'll collect them an hour after. So you only leave them out for 1 hour, and then you put the top on and you incubate them, and you can do that again. So you can actually see from the beginning of the day to the case to the end of the case how many bacteria are on the plates. We should have less than 5 to 10 in a room. Now, this is more than 5 to 10, and these were taken at the last hour of the case. I wanted to show them that all that movement in the room at the last hour of the case, where you might have circulators counting sponges and maybe even orderlies trying to get things ready for trash, and the tech is talking to the maybe the instrument rep to get trays put back together, but somebody is still sewing the incision where these bacteria can come and land on them and start to grow. So these are just very easy to do. Now, the other challenge I did, again, I recommend you work with your lab. You'll see a copy of these slides. Take a pure plate of, it's called 0.5 McFarland broth, which is really like pus. And you aseptically drop the suture on top of that medium and let it incubate all night. The top one was at 5 days. I actually had to take this home and seal it up for my kids and say, do not touch this. We incubate it, it will stop the organisms from growing. But then, because they would have thrown it away in the lab. So you can see at 5 days, nothing would grow. I mean, it stopped in its tracks, that amount of organisms to go near that triclosan. Then we held it at 10 days and we could see the same thing, and we showed them a non-coated suture. So we showed this to the orthopedic surgeons up at New England Baptist Hospital in Boston. It was like a no-brainer to them. Why would we not want to switch over to triclosan coated, or with what we call the the Vicryl Plus sutures and use those rather than a non-coated suture. So in 2005, we did a total joint arthroplasty study. I got permission from the chief of orthopedics. Let's just look at these for a year and see if we have a reduction. If we didn't, we weren't going to switch over. We eventually switched the entire system over when we saw the reduction. The end of the year trial, there was more than 3,600 joints that we looked at in this trial. And we had a 65% reduction in Staph aureus, the leading cause of SSIs in the United States, probably the same even in Canada, and Staph aureus, and then a subset is MRSA. And so we had already been driving our infection rates down to 0.3, and we got it down to 0.1 for total joints. We presented this poster back in 2010 at the National American Orthopedic Nurses Association meeting. So what does the meta-analyses show? There are over 30 meta-analyses that have been done now, and they have a range from 20 to 60%, stratified by different types of surgery. So we have the evidence there. We have non-industry supported evidence. So these aren't all, studies that had some industry support. These are clearly randomized clinical trials and evidence that they work. And the other great thing about these is that they're safe. There have been no FDA reports over 20 years that anybody's had any kind of a significant reaction to them, or any kind of pediatric toxicity or chronic toxicity, carcinogenicity, reproductive toxicity. The microbiocidal activity is both gram positive and gram negative. We haven't seen any reports of any kind of resistance. It's always a concern when you use antibiotics or even antiseptics. Evidence-based research is there. As I mentioned, the clinical trials, the randomized clinical trials, and cost-effectiveness studies have been published. Moving on to solution to pollution is dilution. So we're in the operating room now. We're trying to think, what can we use in the site, in the incision, that will help us to get rid of those contaminants that Peter showed with those videos. And so we published the first paper back in AJIC, the American Journal of Infection Control, in 2014. A group of us were looking at the lack of any kind of evidence that antibiotics, cefazolin, vancomycin, bacitracin, polymyxin, all of these concoctions sometimes that the surgeons will put together, there was no evidence at all in any published reports that they reduced SSIs. In fact, there were some cases with bacitracin of actually anaphylactic reactions with that. But, again, there was no evidence at all. And at that time, we started to see some antiseptic irrigations coming into the country. One of them was a very small 0.05% CHG, which is in this picture here. This was actually, I was in a hospital in Washington, D.C., in the operating room with orthopedic surgeons, and they were looking at how to use this antiseptic. So we published this paper in 2017 and really trying to get the word out that now that we have antimicrobial stewardship committees, this was a result of our joint commission putting this under medication management under their module for joint commission standards and recommending you establish antimicrobial stewardship teams and committees. Well, it made sense that they should talk about this, the lack of evidence of using topical antibiotics in open surgical wounds, and start to talk about using antiseptics. Well, from that point on, since 2009 is when the CHG product got FDA cleared, you can see all of these different antiseptics that are now being marketed to be used as surgical irrigants. If you have orthopedics, this is one of a really good study from 2021 in the Journal of Bone and Joint Surgery Infections, JBJS, we call it. And it was really the pursuit of the ideal antiseptic irrigation solution for periprosthetic infections. And you can see, again, all of the different povidone iodine, chlorhexidine, acetic acid, and so forth. So you really probably are going to need a team to get together, look at the research. There's even some new research just recently come out where they're comparing these different antiseptics to one another to see, do they really reduce SSIs? Or just sometimes just flushing the tissues out with things like saline, would that work? So it really does take another subset of your team. There's going to be teams that are looking at various things, and this would be a team that would look at these antiseptics. I actually had the pleasure of working with Peter back in 2015 to 16 where I was the corporate director at Universal Health Services. At the time, we had 25 acute care hospitals across 7 states in the United States. And Peter and his team of clinical specialists came in and actually trained our colorectal surgeons on how to use this CHG irrigant. My feeling was that the highest infection rates we were seeing were in the colorectals. And if this would work in that group, then I think it would make sense that this would work with C-sections and hysterectomies and others. And it did work. If you can see in the lower right-hand corner, our National Health Safety Network, where we report our SSI infections to the CDC, we were able to get a statistically significant reduction in our SSIs over that year that were related to colorectal surgery. The last one is skin closure. So you can see we're kind of working from pre-op, intra-op, and now we're going to send them home. And you know, a lot of these cases going home same day surgery, whether they're total joints or other kinds of major surgeries that are being done. We have no idea what kind of an environment they're going to and what their incisions look like. So at New England Baptist Hospital that did over 12,000 orthopedic cases a year, I had formed a team that involved PAs, our physician associates, our nurse practitioners, our wound care nurses, as well as clinical educators. And we went out and started to take pictures of post-op incisions to show the surgeons what they look like. I don't know how it is in Canada, but in the US, they'll say, I'll see you in 6 weeks. You know, like, we've done the surgery, we've done our part. Now you need to heal, and I'll see you in 6 weeks. And they were kind of shocked when they started to see that, like the second picture down to the left there, that was a picture that I took. And here you've got steri strips, there's sutures, and you can see fecal material on the bottom and dehiscences that start to occur. And you can see the redness, the reactions to staples. So we needed to start to show them that we had what we call challenges with post-op dressings because of the techniques that they were using. So we started to talk about consider if it's appropriate for that incision, topical skin adhesives. Let's seal them up. We call glue them together so nothing can get in. And what they do is they give them in the first 72 hours, what's called the exudative stage of wound healing, where all of the wound cells are migrating to the wound bed, things like fibroblasts, the epithelial bridging is going to occur to really seal that incision. But the macrophages, that part of the immune system that eats up anything that's fallen into that incision, not just bacteria, but lint and other things, and processes it to get rid of it. We want to be able to give that protection in that first three days. And then from 3 days to 3 weeks post-op, they go into the proliferative stage of wound healing. Now, many of us aren't telling the patients this. We just send them home. But to have a wound that has 7 days of wound healing strength is what you get when you use topical skin adhesives instead of using sutures and staples. Now, this is the old type of this incisional adhesive way back, you know, back in probably 2010, where the surgeon sent me these slides and he said, you know, I put it on, I let it wait 1 minute. That's how long it takes to dry. And then he liked to put a piece of Telfa and then cover it with transparent dressing and leave it on for 2 weeks. This was one surgeon that saw his patients in 2 weeks. And when he took it off, beautiful healing and cosmesis. The other nice thing about that, if there was erythema or any kind of drainage, they would see it right away. They were able to get that patient to come back in again. Another area that I was able to resolve these high infection rates, I started at that hospital in 2003, and they started to do total shoulder replacements in 2004. All of a sudden, I started to get these infection rates as high as 2.4%. And, you know, we're doing the 7S bundle, we're implementing all of these things. Finally, I said, I got to go into surgery with this. There were only 2 surgeons that did these replacements. So I said, can I come in and just watch and see what's going on? Well, he takes out the staple gun, and I was like, oh my gosh, I had no idea you were using staples. That's the area with Cutibacterium acne. It used to be called Propionibacterium acne or P. acne. It's now called C. acne. That's an area where they grow up in the shoulder and the back of the neck. They cause a lot of those little pimples sometimes you get up there. And so they were puncturing the skin and these organisms were getting in. So we switched them over to incisional adhesive and they sealed it up. As you can see on the right, they put a sterile ABD, covered it with the transparent dressing, same thing for 2 weeks. And they have not had a total shoulder infection since they implemented that back in 2010. The other area that we had great success was eliminating the use of staples or steri strips. for patients who had C-sections. It was kind of a directive through our quality patient safety council at Universal Health Services at the corporate level that we wanted surgeons to stop using staples. Yes, they're fast and they're easy, but the problem is they take them out typically on day 4, and then they send the patient home. Now you've got a baby, you're going to breastfeed, it's going to be sitting on your large abdomen. This wound is just starting, as I said earlier, the proliferative stage of wound healing, and they dehisce or they start to get infected. So this is a great area where you can start to use things like topical skin adhesives or the polyester mesh skin closure system instead of things like staples. So that's what this polyester mesh system that started to get marketed, and we started to switch from just using adhesives to using this. So this is a unique combination of 2 components. You have the 2-octyl cyanoacrylate. And I just want to mention, if you went to your pharmacy, you got your liquid, like a liquid type of adhesive, that's usually a butyl cyanoacrylate. It's not very strong, but it's really good for little slices that kids might get, little kind of a wound that you want to kind of glue together. This is different. The 2-octyl cyanoacrylate is very, very strong, and it has a microbial protection. So it will actually kill bacteria in the wound bed. But now you put this mesh over the incision and put that on top of it. Again, it only takes a minute for it to set. And then you've got this really nice initiator that accelerates this polymerization of liquid adhesive. And it's like a tape dispenser, basically, but it's good for long incisions. I've seen it used on cardiac, on the mediastinums. I've seen it used for orthopedics, especially a lot of plastic surgeons will use it. Now, this study just got published. This was 2025, the Journal of Maternal, Fetal and Neonatal Medicine. But look at these outcomes, the results that they had. Reduction in inpatient readmissions, emergency room visits, kind of other kind of outpatient visits. But the one that I'm most interested in as an infection preventionist, the 30-day incidence proportions of C-section SSIs or dehiscence were reduced by using a mesh system with the topical skin adhesive. Now, some patients are allergic, unfortunately, to adhesives. That has to be something that is asked, as you know, during, are you allergic to anything? Are you allergic to adhesives or Band-Aids? This is a situation when you would not want to use that. All I can say is, because we did pull together a post-op standardization committee. We went after we did all those pictures, and then we started to see, yes, we did have some patients that were allergic. So we got a team together. We had a wound care specialist, some members of the OS staff, a PA, a nurse practitioner, surgeons, and educators on the team. And we looked at antimicrobial gauze dressing. The one we were using had polyhexylmethylene biguanide in it. It's a PHMB antiseptic, a very mild antiseptic and these didn't cost as much as the silver. One thing we learned about silver when we started to work with the companies is you have to have some exudate in order for the silver ions to work in the fluid. And many of them will absorb, one of them was like 22 times their weight in fluid, almost like a baby diaper. It would suck up everything, keep it on top of the wound bed, and the body could go through autolytic wound debridement, where all these cells could work in that liquid medium with the silver killing the bacteria. If you don't have that exudate in there, then you're wasting your money. And we found that with some of our hips and knees, they were dry. There was no need to spend the extra money for silver. And then there's even more elaborate incision closure devices like the one on the right. So all I can say is this would be one that you'd want to get a team together and look at. And don't forget your drains. If they're still using drains or thoracic tubes or whatever, we use it for central lines or dialysis lines where we would put a CHD disc around the insertion site so the bacteria cannot migrate up that catheter or that tube or drain and cause an infection. So this is an area where you can use that CHD disc and cover it with the transparent dressing. And also in our CDC guidelines from 17, there's recommendation not to use antimicrobial ointments. And I do remember this back in, I've been around infection control for a long time, the 70s, when iodophors first came out as a solution. And then they thought, well, let's make an ointment. So they made the ointment and we started to slather that, not me, but the nurses all around these insertion sites. Well, iodophor will come out about 2 hours, it will do its work. And then what happened is that ointment sat there as just this gunk and started to grow fungus, especially candida and fungal organisms in it. So it's not recommended to put any ointments on incisions. I've heard certain surgeons telling me, oh, well, I want the nurses to put bacitracin on the incisions post-op. We're like, no, that could then cause them to have an increased risk of infection if you start to put them around insertion sites or incisions. So you want to consider what's called a wound closure bundle. You can see here you've got a paper that we published back in 2018 in the American Journal of the AORN Journal. And this was for colorectals. And so you can see the list of elements, bundle elements that were for that. You can also need to have a bundle that controls bleeding. As I showed you earlier with the blood agar plates, they love blood. They love sugar. We have sucrose plates in the laboratory. So this is why diabetics are such an increased risk of having infections. But you want to have effective hemostasis. I remember back in 2010, I had an increased incidence of hematomas happening in our patients, and we couldn't figure it out at first, and they were leading to infection. So I did a case control study with one of the fellows, and we didn't kind of realize that that was the year they started to use Lovenox and Plavix, and the dosing was off, and patients were having a lot of bleeding because they had problems with their clotting. So you want to make sure that you have really good hemostasis. This does have bactericidal properties. It also is absorbable. It typically breaks down within 7 to 14 days in the body, conforms to the tissue, and it's an adjunct to other hemostatic methods that they use. So this would be the first thing, is to make sure if this wound is likely to bleed, that they consider using a hemostatic powder or product. The other is antimicrobial knotless tissue control devices. Now, I'm not a surgeon. I don't know that painstaking. I've watched them and tying a knot, going in, tying a knot over and over and over again. There's these knotless types of tissue devices that have barbed wires on them. And it's really cool to see. If you can see, go on YouTube and look at a YouTube video of these. They are triclosan coated sutures as well. And again, there was one study that showed that they had close to a 30% reduction in SSIs than the control group that they didn't use them. So it's almost like some of these, sewing techniques where you go through and then you pull it and it just ties them together really nice. So they don't have to have all of those knots. When it says knotless, for me, that's important because the knots are where the bacteria, if they get in and start to have that, every 20 minutes grow in the organisms, you get a stitch abscess, or you get this little igloo of that sticky matrix around them. And that's very hard for antibiotics to get in. So when you look at a wound closure bundle, it looks something like this: a hemostatic powder, the Vicryl Plus antimicrobial sutures and wound closures that would include the mesh tape or just even the incisional adhesive. It really depends on the type of incision. So do the bundles work? We have pre-op elements for our bundle and intra-op elements of the bundle. At New England Baptist Hospital, it worked. And you can see our different movement, 2 standard deviations down. I was there from 2003 to 2010. And even despite all those things we implemented, I had an increase in laminectomy infections in 2007, case control study, trying to figure out what was the difference between the infected patients and 4 controls that were not infected. All of a sudden that year, they started to use locally administered steroids and start to put them into the incisions to reduce swelling, they thought, and pain. Well, unfortunately, it wiped out the immune system. We had this increased infection rate. So we stopped it. Infection rate started to go down. Then I get an increase in knee infections. Started to look at this. And that was the year they started to use these concoctions of pain medications, these cocktails of Duramorph, Marcaine, and Toradol. But my infection control champion in the OR, because I had a champion program, said to me, I think I know what's going on. They're drawing up all 3 medicines with the same needle, squirting it into a sterile specimen container, and then passing it to the field. The organisms were alpha strep and coag negative staph, things that are from the environment or from the mouth. It wasn't Staph aureus or gram negatives. So that led us to think it had to do something with the environment. And then the last one was, as I mentioned, the post-op hematomas. This is pharmacoepidemiology. So sometimes it's medications that can cause your outbreaks. And so we published this poster presented at AORM back in 2014 on the 7S bundle. We also did this study with Ethicon, standardizing a wound closure bundle, where they come into our operating rooms and actually looked at the incisions, looked at what the surgeons were using. Did they understand antimicrobial sutures and how to use the incisional adhesive? we had in the 12 hospitals that participated close to a 38% reduction that year in that 25 hospital system. Now, this is another thing you can do with your staff. Ask them, what do you think causes our infections? Give them a blank fishbone diagram with these topics and say, you tell us what you think. Work in teams. You do the pre-op, you do the intra-op, you guys do the patient factors. You'll be shocked at what they come up with. I mean, every time I do this, it's something like, I didn't even think about that. So, you know, you've got to engage your staff and get them involved in telling you what they think is causing their infections. And we have lots of references for you, and you can, this website is just a free website that we maintain and just, you know, publish in any references and support so that you can learn more about the 7S bundle. So now we're going to open it up to questions from the group.
So Maureen, that was great. Thank you.
Thank you.
I think I've seen several questions come across, and by the way, thank you all for your positive comments. We really appreciate it. Maureen and I had the opportunity to speak at ORNAC in Halifax a few years ago, and it was very well received. And we would love to come back and do this again in 2027. Also, several people wanted to share some of this information with their surgeons or other groups. Reach out to your friends in Johnson & Johnson, and maybe we can schedule a webinar for your surgeons, for example. I think that would be another great opportunity. We had one question regarding, can you use the adhesives in and around the face, the eyes, and so on? And the answer is no. Typically, you'll use that on like shoulder, knees, abdomens, and so on. You don't use it around any orifice, eyes, for obvious reasons. So that was a great. There's another question regarding the use of specialized post-op border dressings.
Yeah, Mepilex is good. Yeah, I like Mepilex. That's a great, that product we used a lot with our patients. Actually, one of the slides, if you, the one where I showed you the challenges, the very first one, the upper right, you'll see a Mepilex on an area where a piece of skin was pulled off by paper tape or silk tape. Will pull, it sucks into the tissue, especially if they're lying on it. And when they go to take it off, it just takes a chunk of skin off. So we used to use the Mepilex on that. But there are so many, that's a good question, because again, it brings up the fact there's just so many different types of dressings that, and your best thing is if you can try to corral them in and standardize them, it makes it worth it. It's very cost effective, and it's better for the patients to have things that are more of a standardized protocol. Get the surgeons on board. It's more cost effective as well. And we showed that. We presented a poster on that at NAON as well on our standardization program for post-op dressings. So, and a lot of people talk about Stratafacts. That's great, you know.
So there's a couple questions about, they're using things like low concentration chlorhexidine gluconate on select patients. They're using Stratafix on select patients.
Yeah.
The one thing I would always recommend is, you know, why are you using two different types of irrigation? Standardize so you can actually measure the results. And I think, Maureen, that's something that you and I did with that colorectal study. Yeah. Was we standardized our surgical irrigation. If you're still using antibiotics to irrigate wounds, you're wasting two things. You're wasting your time and you're wasting your money. And so I think one of the things that antibiotics are not designed to work as a topical antiseptic does. And so I think that's one thing. The other thing is if you're carrying more than one type of suture that can be replaced with an antimicrobial suture, they handle it exactly the same way. So standardize to your coated antimicrobial suture rather than carrying a non-coated or a coated. Standardize, because they typically are little to no difference in price, but your outcomes will be drastically improved. Angela showed that in her data, as did Maureen. So I think that's a really important information. And again, please feel free to reach out to us. We're very happy to answer your questions offline. But let me see if I missed any questions.
I want to answer two questions, Peter. Okay, wait a
Sure,
minute.
absolutely.
So we decolonize staff. Okay, that has come up a lot. And there's actually one study where they looked at this alcohol nasal antiseptic, and it's about 10 years ago, this study. And they showed the reduction. They took cultures of the nose of the staff and then showed after use the alcohol antiseptic, which also has orange oil in it and jojoba and benzalkonium chloride. We use it in the United States. And they found a dramatic reduction in Staph aureus and even gram negatives and all the others. They had two charts showing really kind of a wipeout of gram positive Staph aureus and then a very significant reduction in gram negatives and fungus. But it's never been a recommendation. The only time I've ever done it is if we had a cluster of MRSA or even Staph aureus, we would culture the staph. And if we were able to match by pulse field electrophoresis the organism in the nose of the staph and in the patient, which was rare, usually it's the patient's own organism that would match with what they got in their infection. Then we would decolonize the staph, but it's not like a routine thing. We did have an outbreak once in a NICU where we had done everything. We were doing gowns and gloves, and nobody could bring their cell phones in, and an antimicrobial, hand wash. We did everything, and finally, I said, you know what? Let's implement the this alcohol-based antiseptic for the nose, and we did that, and it cleared up the infections because people would, touch their nose constantly. The other one was about anesthesia and masks. All I can say is take blood agar plates in front of people and have them talk. Just give it a bunch of blood and have them talk, have a conversation, and then incubate them and bring them back the next day and show them what's all over the plates. The other one I did was I took cultures of the back of their necks when they didn't want to when they want to wear the skull caps with all their hair hanging out. I said, well, I'm going to do Rodak plates. They're called, or contact plates. And we cultured, we had no names on the plates, anesthesia and surgeons and residents. And then I brought them up the next day, sealed up so nobody could touch them. And they saw the bacteria all over them. They sweat under those overhead lights. It's hot during surgery. So, this is the way I used to work. I used to really try to bring it alive for them so they could actually see the organisms, and that would influence the behavioral change. But they have to.
I was going to add one. I was going to add one other thing about mask wearing. We should have learned a really important lesson during COVID about aerosol generating procedures, and masks are a significant protective device, particularly in and around aerosol generating. And anesthesia during their intubation should definitely be wearing a mask, as well as eye protection.
Yeah.
And Maureen and I, we call out those behaviors when we go into facilities to do surveys, for example. And we could go to your facility and do the same thing, and we would have one-on-one conversations with anesthesia about the importance of wearing a mask and eye protection, because aerosol generating procedures, it's not just about COVID, it's about a variety of other microorganisms that could be transmitted via particulate or particles or airborne methods. So I just want to say thank you to everybody for your time and attention. It's been great. We enjoyed our time with you, and we'd love to come back another day.
Simply outstanding. So much information to think about, so beautifully presented, and the data, wow. Thank you so very much. Really appreciate everybody joining us tonight. I think I see the numbers are up to about 110. And a big thank you to J&J, as always, so supportive of nurses education, and we can't thank you enough. I do see that Jillian has put up the QR code. We'd really like to get some feedback from those of you on the session tonight. So if you could take a photo with your camera and follow the prompts, that would be really great. Everybody is always welcome to join. We don't charge for these to our members. If you're ORNAC member, Ontario or otherwise, you're welcome to join us. It's about sharing and learning together. Thank you very much to both Peter and Maureen. Your experience and expertise and presentation ability is just outstanding. Thank you so very much once again. And with that, I think I will call it an evening at 8:35. Thank you so much. Good night, everybody.